How do plastic surgeons take an aged neck and make it look 30 years younger? That's today's topic on Aesthetic Minutes Clinical Vignettes. Hi everyone, welcome to Aesthetic Minutes Clinical Vignettes. On today's case, we have a 48-year-old female interested in improving the appearance of her neck. Although her primary concern is the aging of the neck and the loss of a youthful cervical mental angle, she also demonstrates mild aging of the lower face. Aging of the neck is always tied to aging of the face, which is why plastic surgeons typically employ a facelift to rejuvenate the neck. However, choosing which technique to employ in a patient requires us to evaluate each of the subregions of the face and neck to determine which type of lifting techniques are necessary to achieve the best result. These distinct surgical regions include the upper face, the middle face, and the lower face, as well as, of course, the neck. Let's begin with a top-down approach. At only 48 years of age, this patient has predictably very little aging of the upper face, with brows positioned high and minimal upper eyelid skin excess. Although there is moderate volume loss of the temporal region, this patient has favorable orbital aesthetics, with still youthful feminine features. Similarly, the midface shows little aging. Although there is some loss of midfacial volume in the medial cheek and some malar areas, cheek soft tissues show no significant descent, with only mildly prominent nasolabial folds. This patient therefore requires no surgical lifting of the upper face or midface, which is good news as it means less surgery and therefore a shorter recovery. This is one of the reasons why plastic surgeons typically recommend that patients first begin considering a facelift at around the age of 50 rather than waiting until their 60s or 70s. The longer one waits, the greater the amount of surgery that will be necessary to completely address all of the aging of the upper, middle, and lower regions of the face and create a natural result. Pursuing a surgical facelift early results in better aesthetic outcomes with less surgery and thus a shorter downtime. Let's take a look now at the lower face and neck, which will help us determine the type of surgical intervention to use in this patient. The lower face shows some evidence of aging and excess tissue laxity, with mild jowling and early marionette line formation visible on exam. Nevertheless, this patient has a favorable jawline that, although partially hidden by the jowl, is still aesthetic and youthful. Remember, the goal of facelift surgery in correcting the jowl is to actually improve the jawline. If severe bone loss of the mandible exists, such as seen in some older patients, then the surgeon should plan on correcting that as well in order to achieve the best results. Because the lower face is the only facial region demonstrating evidence of tissue laxity as manifested by the jowling, the facelift technique does not need to be aggressive. For this patient, the lateral SMASectomy technique developed by Dan Baker in 1994 is both sufficient and ideal to address her mild lower facial aging. The lateral SMASectomy technique employs a true muscle lift by removing a strip of the fibromuscular layer of the face called the SMAS or SMAS to tighten the lower face and neck. This technique has remained one of the most popular facelifting surgeries of the last 30 years due to its safety, short operative time, and quick recovery. If you want to brush up on the differences between the different types of facelift techniques, feel free to watch the Aesthetic Minutes video on that topic. Let's take a look now at the last but most significant anatomical region in this patient, the neck. Examination of the neck reveals excess skin and muscle laxity as well as excess fat deposits in the central neck. The excess skin and muscle laxity occur due to the gradual distension of the platysmal muscle, a thin muscular sheet that sits beneath the skin, which creates the appearance of neck bands and skin wrinkles. The excess fat, on the other hand, causes the neck to look bulky and full, diminishing its contour and profile and blunting the cervical mental angle. The laxity of the skin and platysma, along with the excess fat, are all easily addressed with the most basic of facelift techniques. However, the examination in this patient also reveals excess fat deep to the platysmal muscle, which requires additional surgery to correct. In the neck, fat deposits can typically occur in two different planes, subcutaneously, meaning underneath the skin and sitting on top of the platysmal muscle, or subplatysmally, located deep to the platysma muscle. In most facelift patients, excess subcutaneous fat is very common and is easily addressed with simple liposuction of the neck. This liposuction of the neck fat is so common that almost every surgeon performs it as part of their facelift technique because it helps to improve the overall result. However, in this patient, there is also significant fat accumulation deep to the platysmal muscle, which places it out of reach of liposuction. For the surgeon to remove this fat, an open surgical approach to the neck is required, known as an anterior platysmaplasty with an open subplatysmal lipectomy. In such a procedure, a 1-inch incision is made in a crease under the chin. Then, the skin is undermined and the platysmal muscle is incised along the midline. Next, the subplatysmal fat is removed and the muscle edges are reapproximated, significantly improving the contour of the neck in the process. Although the platysmal plication and the subplatysmal lipectomy make the facelift more invasive and time-consuming, they can yield the most significant neck rejuvenation results. To learn more about other surgical techniques employed by plastic surgeons for neck rejuvenation, feel free to watch the Aesthetic Minutes video on that topic. This patient underwent a lateral SMASectomy facelift with neck liposuction as well as an anterior platysmal plication with open subplatysmal lipectomy under general anesthesia. The procedure took approximately 3.5 hours and required 1 to 2 weeks of social downtime. Here are this patient's results 3 months post-procedure.